I'm Steve Campbell with Marketing and Communications, and I'm happy to welcome you to the fourth and the last session in this series of Mondays in March this year, which we had entitled Mission Critical Conversations on the Future of Improving Health. Over the past 3 weeks, I think we've had some great discussions about those big things that UTMB is experiencing. What's going on in the marketplace? Why do we really need to continue to grow? What's really happening in the health space that's causing us to evolve or sustain a revolution and make really major changes? And how does the academic foundation support all of those missions, and what are they being pressured to do as well within this changing environment? All of those are actually out on the Mondays in March site on UTMB. If you weren't able to watch those or attend before, I would really encourage you to go out and take a look at them. And actually, even if you did, you might want to take a look at them again, because I think there's some really, really good information out there. Today's session is really a wrap-up session where we're going to re-emphasize some of the things that we've learned over the last 3 weeks, address many of the questions that have actually come in through the EAC, and take a little bit of a look forward with our leadership team. Our moderator this morning is Dr. Ben Raimer. He's our Senior Vice President for Health Policy and Legislative Affairs. And the panelist was Dr. Bhardwaj, our Provost at interim, Cheryl Sadro, our Chief Financial Officer, and Donna Sollenberger, our EVP and CEO of the UTMB Health System. With that, Dr. Raimer, take it away.
Thank you, Steve, very much, and thank all of you for being here this wonderful afternoon. It's going to be a great day. And sure as I say that, we'll go outside and it'll be raining, right? No, it's going to be a great day. You have three of the best leaders in America in healthcare sitting before you. I'm not one of those, by the way. You can count to my right. 1, 2, 3. They're excellent. We have gone through a series regarding the case for growth, and we learned a lot about our expansion of patients and the recruitment of healthcare providers and the improvement in IT and IS that's before us. We spent some time in the healthcare evolution or revolution space. I'll have to ask Donna, does she have an arsenal at home? And these other folks, what sort of tools that they're using. And we discussed why best care is still a very relevant and important thing. We also looked at our academic foundation because we are indeed unique. We're an academic medical center. And for the historians in the audience, you'll recall that our hospital and our medical school were actually the first in that paradigm, preceding Johns Hopkins by 1 year. So we should know by now a little bit about the academic foundation and that space. I wanted to ask some challenging questions today, at least I hope they're challenging, to our experts. We've had a lot of input through the internet and online for questions, and just some things that we have suggested among ourselves. So I'm going to start out by asking our experts up here a very forthright question, and that is, of all the things you have accomplished this last year or two in your domain and your entity, what is it you're most proud of in this past year? And I'm going to start with Donna and just go down the line. So Donna, in the clinical enterprise, what is it that you're really proud that you and your people have accomplished?
I think it's really the Vizient ranking is number 4 in the nation. It's the ranking, as you all know, because you've been working best care right alongside us, that evaluates organizations, academic medical centers, there were about 100 of them this year, for their excellence in patient-centeredness, equity, effectiveness, quality or safety, and mortality. And when I think about where we were when I came almost 10 years ago, it was one of the things I asked for first, that ranking. And if I recall right, that year we were something like 82 out of 107, 102. And I think that the work that has gone into creating an environment that has produced those kind of results is nothing short of extraordinary. And I think I'm most proud of it because it took everybody, and it's not just everybody in the health system, but everybody in the organization to help us achieve those results. And if we stop for a minute and we get a little heady about this, the only 3 organizations ahead of us were Mayo of Rochester, New York University, and Rush out of Chicago. And Rush has been in the top 10 virtually for every year since the study started in 2005. So that would be the thing that I'm most proud of this organization for achieving, and I'm really happy for our patients and our staff who work so hard to get that recognition.
Thank you, Donna, and congratulations on that achievement. Dr. Bhardwaj, I'm going to ask you the same thing. The academic enterprise has undergone some incredible challenges and changes over the last several years. And you've been in that mix the whole time, working previously with Dr. Jacobs and now as our interim. What is it you're most proud of over this last year or two?
Thank you, Dr. Raimer. I'm going to give a slightly longer answer than Ms. Sollenberger. I think, first of all, recruitment of leaders. I think we're extremely proud of recruiting Dr. Deborah Jones as the Dean of School of Nursing, David Brown as our Health Profession Dean, and more recently, Dr. Merkley as the Chair of Ophthalmology. I think these are top leaders, vetted very much so across the country, and we look forward to enhancing our schools and collaborations with these leaders as we move forward. Now, in the clinical realms, this is in Ms. Sollenberger's domain, but we are extremely proud that we've been able to really collaborate with the health system and bringing forth League City campus collaboration, as well as more recently the Clear Lake campus, trying to have a hybrid model, have credentialed 151 physicians, and we're going to create this network of physicians and really extend our services into the inland. On the faculty development and faculty affairs side, we are extremely proud of setting forth an Office of Faculty Affairs and Professional Development that is really focused on developing our leaders of tomorrow in terms of sending them out to national meetings of AAMC and minorities, taking the challenges of inclusion and diversity and creating more creativity in our leaders and across schools and collaborations as well. We are really focused, we have been focused quite a bit on faculty wellness and burnout, which we'll continue to do, which is a real problem as we move forward and needs to be addressed very carefully. In the area of education, I think with the leadership of Dr. Sutherland, we are really excited about the Health Education Center coming up with interprofessional education and how we move forward across schools. This is a really exciting area, and we have done much in that, and I'll talk more about that. In research, again, restructuring the research office under Dr. Urban's leadership with a renewed focus on clinical research, bench to bedside, and vice versa, I think is going to be the focus. Collaborations on campus as well as between institutions. Thank you, Dr. Raimer.
Thank you, Dr. Bhardwaj, for the hard work of you and your executive team, all the chairs and others. Ms. Sadro, so I'm going to have the same question for you. You may have a little different perception there, of course, but what are the things that you are most proud of accomplishing in the area of finance this year?
I'll take it a little broader, if I may, than just finance. I think that the Clear Lake Hospital has been something that we should all just be incredibly proud of this year. We went in and weren't sure we were actually going to be there, but we negotiated with that team, and there was a group that did that. And once that negotiation was complete, there was another group that kind of took that ball and ran with it. And up until this point, when we will open it on Saturday. So to me, that represents a tremendous amount of teamwork within our organization across many different disciplines. And I think for us to be strong, that's what we really need to do. So from an organizational standpoint, I really find that just to be fascinating. I also think, although it maybe isn't the funnest thing in the world for a lot of folks, but I think how we have answered the call to work with Huron, to work with BRG, to position our organization so that we can make changes, so that we can do things like Clear Lake, so we can advance our research and education. And we'll talk a little bit more about those consultants I know later. But that's hard work. And it's not fun work all the time. But the organization has really come together through all missions and really risen to the cause. And then I think lastly, and you've heard me probably say this, the work that's been done, again, across all missions with UTMB Discover, I think we really need to embrace what a gem we have developed as an organization and the power it gives us in terms of data and how we can use that data to move our organization forward. So in terms of this year, I think those are probably the top three that I would say organizationally that we're really proud of.
And I think our audience should get the impression here, because it is reality, that the three of you work very closely together with Dr. Callender. This doesn't happen by accident. This is a premeditated plan. It's executed in certain areas, but it's all a vision that has coalesced around each area. So I'm going to jump to another subject here because it ties into that. We are surrounded by optimists, and we hear all these reports. We know that our increase in students and enrollment has grown over 40%. There has been unprecedented growth in the clinical enterprise, and although the financial challenges have been great, they've been met with ingenuity and hard work and good results. So many of our employees look at that and they want to know, is the pressure off now? Can they take a breather? Can we kick back and relax and just celebrate? Or is this the environment that healthcare is going to be in for a prolonged time? I think that's a fair question. It did come into a number of sources. So I'm going in reverse here. And Cheryl, what do you think? Is the pressure off?
I guess the easy thing to say is no. And that's just the world that we're going to live in. And I think if you've heard Dr. Callender speak any time in the last year, he certainly has echoed that sentiment. The world is just changing around us, and to feel like we can be status quo, it feels good, and it would be a great place to be on many levels, but it's just not reality for healthcare. There's so many things changing. My colleagues certainly can speak to a lot of the details much better than I can, but from, we say this a lot, and we keep saying it so people hear it, but from the payer perspective, whether it's governmental payers like Medicare and Medicaid, if it's TDCJ, or if it's the big commercial payers, the Blue Crosses, the Aetnas, the Uniteds, they're not going to continue to pay us like they have in the past. And we continue to see downward pressure on that. Now, is that bad? No. It's not comfortable, but how we react to that is really what's important. How we get to our new normal is what's important. So you'll see, and a lot of work's been going on for a couple of years now, we're moving to those ACO contracts, accountable care organizations, where a lot of what Donna spoke about in terms of Vizient plays into how we will be reimbursed. How are we graded, I guess, if we can say that in an academic institution? How are we graded on our quality? What are we doing to keep people healthy rather than just fix their illness? Those are the things that the payers are really looking at. And we don't all in this room do what we do to get paid, but we have to get paid to do what we do. So that is very important. And it's going to we're going to continue to need to find innovative ways to do what we do. Some people chuckle when I continuously talk about my daughter and wanting to get her health care on her phone. That's the way the world is moving. And the students that we have, not just only here, but across the country, and you guys probably know this better than I do, they don't always want to come into four walls and learn what they have to learn. So how do we still provide the appropriate education? How do we afford that? But how do we also meet the needs of that population who, unless you're really different, are probably much more savvy than I am in technology? But that's how they want to learn. So the answer to, are things going to get better, and are we going to be able to sit back in the rocking chair and enjoy the slide into retirement? No, we're not. But it's also exciting and challenging, and we really just need to think outside our comfort zones and our boxes on how we're going to embrace this change. It will be very exciting, but it will be hard work as well.
Dr. Bhardwaj, sometimes employees always think they're greener pastures. And I know that retaining faculty is always a difficult thing for a provost or any dean. You've just come back from the AAMC meeting. Is UTMB the only place where that's an issue? Are people likely to just move somewhere else and find a utopian academic center?
If they are, let me know where it's at.
Well, like Dr. Raimer said, I just returned from the AAMC meeting last night in New Orleans. And I have to step back and talk about academic medicine in a global sense. First, I think academic medicine is changing very quickly. There are enormous challenges, but that brings opportunities as well. We must remain very strong in terms of trying to fulfill the tripartite mission, the excellence in clinical service, teaching and training, and research and scholarship. And that is our goal. Now, these are clearly challenging times in terms of revenue streams. One thing that clearly brings forth revenue is clinical service. State appropriations and support has remained flat, relatively so, over the last 3 to 4 decades. The opportunities that are there are philanthropy, for example, other research funding bodies like tech transfers, collaborations with pharmaceutical companies, and so on. So revenue generation is important. Like Ms. Sadro says, we are going to be moving towards fee for value rather than fee for service. And that brings up newer challenges, a lot of market forces, a lot of competition in the market, and we are doing the right thing by moving inland. Now, coming back to your question about retention, I think we have to identify people early, create pipelines. We have to retain our own people. We have a great tradition here of a medical school established in 1891, or more than 125-year history, and we have been the premier medical school in Texas. And I think we need to have people that are groomed in the right way, in the right pipeline programs, and identify early strong mentorship programs, and remain competitive in terms of finances as well. Competition is always going to be intense. Successful people, Harvard, Hopkins, UCSF, they have always formulated a methodology whereby they grow people and then send them out. And they deem that as a success. And leaving an institution is not necessarily a bad thing. It happens often. It's disheartening sometimes when you have faculty who are not funded for a long while and they suddenly get enormous amount of funding and they become very marketable. And sometimes they get enormous packages outside. And sometimes it's difficult to compete with those packages. So got to have the right perspective, and but strong mentoring, listening to your faculty, chairs, listening to the faculty, mentor-mentee relationships. Those are the things that are going to enhance our retention of our faculty.
Thank you, Dr. Bhardwaj. Donna, I know that you probably have many sleepless nights, that there are things on your agenda. I suspect you're one of those people that has a little notepad beside your bed and a pencil so you can write things down. So on that pad, if we were to just walk in one day and look at it, what would be the things that in those wakeful hours that you write down and say, these are my priorities, here are the things that I'm worried about, what I need to do? How do you go about setting that list? We've been the beneficiary of your knowledge and wisdom. How do you do that?
I don't keep a notepad there, but I get up sometimes and go to the dining room and write things down if it's a really great idea. So, if I were saying what are the three things I worry about most, I worry that we're going to have the healthcare workforce to do what we need to do. That's staff, it's nurses, it's pharmacists, it's doctors, the whole package. And when people talk about UTMB, to me, it's not a building, it's everybody's faces. That's UTMB. Yeah, we can say we have geography and, you know, there's this building and that, but at the end of the day, are we going to have the workforce in the right numbers, in the right places, with the right training, and the ability to adapt, because the change isn't going to let up. But what we can do is, as an organization, try to make sure that we are doing the best that we can by our employees, because you all make UTMB. And I know last year was tough because we went through some rough times, and it may not have always or it felt as if employees were paramount, but there was a lot of angst, at least I know in the health system, and I suspect throughout the organization, about some of the changes we need to make. I don't want that to happen again. We have to stay ahead of the curve. And to do that, I think we have to take control of our own destiny. I kind of think about, I'm in a ship with sails and the winds of change are blowing. It can either blow me into the rocks and I can wreck, or it can blow me out to sea somewhere I don't want to be, or I can decide I'm going to take charge and I'm going to sail my own ship. And so I think that we need to do that. Some of the things, I don't know if Vivian's here, Vivian Cardo, but she and I talk, she's the head of HR, and she and I talk about investments we need to make in people. I know my colleagues do, Dr. Callender does. So to me, that's number one. And some of the things we do in education will make a difference in if we have that workforce or not. Some of the things that we do in training will make a difference as to whether we have that workforce that's prepared for the next thing. So people, to me, I worry about that. I do worry about you all too, and about how we make this the best possible place we can for employees to want to come, but more importantly, to stay. The second thing I worry about are patients. Do we have the right technology? Do we have the right infrastructure? Do we have the right supplies and equipment so that the people who are having to take care of patients can do their jobs? And I think that there's always more we can do, and there's more listening leaders should do, myself included. I'm first in listening to thoughts that you all have that can make that care environment better. I want you all to care about the care of that patient as much as I do, because at the end of the day, they've trusted us and we don't want to break that trust. So we have a lot of work to do behind the scenes as an organization to make sure that we can deliver the best care possible every time. We have a culture that, as Dr. Callender says, stops the train if something's not going the way we think it should. Maybe we were right, maybe we weren't, shouldn't make any difference. We were uncomfortable, we stopped, we checked, and then we went on. Or we made a change and then we went on. And then the last thing I worry about is, are we positioning UTMB in the best possible way to not only be viable in the future, but be a leader? We have been a leader so many times. I think when I go across the country and I talk to my colleagues and they hear, for example, what we've done in correctional managed care, people are astonished. And they're astonished because of the innovation that we've had to use in order to manage a distinct population of patients. So are we always trying to innovate and be able to position ourselves? What we're doing, is it always positioning ourselves for the future? Cheryl brought up the Clear Lake Hospital. Other people have asked me at times, why do we build so much on the mainland? Are we going to shutter the Galveston campus? I brought my notes because I don't remember all the statistics always. But if we look at our inpatient growth alone, patient discharges from the island with island zip codes from FY15 to 18 grew 16%. Patient discharges with mainland zip codes that came here and were treated and discharged was a 5% growth. That growth has been critical to our future. And outpatient has the same kind of, actually even more phenomenal growth if you think about it, because patient discharges with on-island zip codes, this actually surprised me a bit, 11%. So we've seen growth in the community, but also how much of that growth came because now people in the community trust us, they want to come to us for care. And there's always more we can do. Dr. Raimer, I read your email the other day. But there's always more we can do, but we've seen phenomenal growth. And if you look at the outpatient encounters from discharges with mainland zip codes here, this didn't surprise me. So we've seen a 20% decline there, but if you think about MR, CT, blood draws, and so forth, people are going to stay in the community that's closest to them for the most part, if they can ambulate. But if you look at the clinic's visits, on-island zip codes, and this includes RMCHP, that have been coming here, a 27% growth, and mainland zip codes, an 18.5% growth. That is phenomenal. So we want to continue that because we want to have a strong UTMB going forward. So those are the three things that I think about most.
We'll get to your colleagues in a second. I'd like to know what makes them reach for the Tylenol at night too, but hopefully nothing stronger. But one thing that I have noticed around the legislature is the collaboration between UTMB and MD Anderson is headline news. It is now the topic of discussion in the legislature, is a benchmarking example of what other higher education organizations should be doing in their community. So I have a question for all of you. And that is, and you can just chat about this among yourselves if you'd like, are we likely to see more partnerships and collaborations like the Anderson one? And if so, what would they look like?
So let me go first. I think I'll start by, this is not a profound statement, but it's true, that we can't be good at everything. And that is the reality. And how do we go about really excelling at things? And that is both collaborations on campus in the schools, and I feel very strongly about that we must enhance our collaboration in the School of Health Professions, School of Nursing, and School of Medicine, and across institutions. I think this collaboration with MD Anderson is a great welcome thing. There are trepidations about that, but it is a win-win situation. I think we have a great cancer institute, and we must enhance both clinical care as well as research as we move forward. Similarly, we must move forward with collaborations with Methodist, and as well as Dr. Urban has moved forward with the University of Michigan. These are the kind of collaborations that we must undertake in terms of proteomics, genomics, and really focus on some of those high-yield research endeavors that are really going to make UTMB move forward very quickly. So in all domains, particularly in clinical and research domains, collaborations which are interinstitutional are really becoming quite important across the country.
Oh. Cheryl?
I think that if you read the literature that I read, and hope you don't, I guess, but if you look at that, and certainly some of what my colleagues see, it's just the wave of the future. And I think when we talked about partnerships, a couple years ago, it was, oh wow, is everybody going to merge into one big conglomerate? And I don't see that unfolding that way. I see it very much in the MD Anderson type partnerships. What do they bring to us? What can we bring to them? And if you look across the country, I think you see those types of partnerships also, where someone has a strength that another individual or another health system, academic medical center doesn't have. They can come together and they can provide their students or their researchers or their patients with an enhanced level of care or science that they couldn't if they just stood alone. So I don't think it ends. I think it continues, and it weaves together a lot nicer, and hopefully a lot quicker. In the healthcare arena, although MD Anderson tends to be an expensive organization because of what they do, not duplicating those services in our organization completely helps the overall cost of healthcare go down. So it's better for, I don't want to sound, all kittens and rainbows, but it is better for the economy as a whole to keep healthcare costs down. So to the extent you can have some synergies around those types of things, I think they'll continue. I think it's better for the patients. I think it's better for research, science, educating students. I think it all plays together very nicely.
Donna?
I'm going to just mention a kind of partnership that is specifically designed around a patient that we're going to need more of in the future. We provide outpatient care and acute and critical inpatient care, but many of our patients on a daily basis, if you look at who needs discharged, they're not discharging to home or discharging to home with no support. They're discharging to home with home health. They're being discharged to long-term acute care or rehab where they get some rehabilitation work done or some additional care that they might not otherwise have, or they're being discharged to long-term acute care hospitals called LTACs. Given that we're going to be responsible for a whole patient's care in the future, and even though we aren't there yet, it's critical that we have these relationships, and to the extent we can or should formalize them, we should explore that, because we need to be able to care for the patient regardless of where our patient is and be able to track that. So I think the future is getting more aligned. Now I'm seeing some of my colleagues across the country, they're buying these facilities or they're creating them. And I'm not saying that's the right thing for UTMB, particularly if we have good providers in the market. But we should be, and we are, trying to collaborate more closely so that we can coordinate the care of the patient, as opposed to have this episode, then they go somewhere else and we don't really understand what's happening, and then all of a sudden they may show back up on our doorstep. We need to do a better job of managing that patient across all the settings of care that they may need. So it's a partnership with a small p, and what Dr. Bhardwaj and Ms. Sadro talked about are really broader partnerships that are critically important. But when you drill down, that's another type of partnership that we need to really think about. And I know Amy Smith and the care managers work on this day in and day out, because we have some challenging patients that we need to place that aren't historically the type of patient that these organizations accept. So we have work to do, but I think that's going to be part of our future as well.
I think that is a key thing. I was very glad to hear Dr. Bhardwaj point out that part of our partnerships, or a large part, needs to start internally. And that's partnerships among departments and different schools as we move through this system of change. It makes us, at least getting some practice at home, it makes us a little better partner, I think, when we go out and look for external partners.
Yeah, if I could, that's a great point, Dr. Raimer, because if I look at some of the feedback from patients, one of the things they tell us is, you all don't work as a team. I have one doctor come in, they tell me one thing, and another doctor comes in, this is a patient, this is their perception, they tell me something else, and maybe another one comes in, they tell me something else, the care manager tells me one thing, the nurse tells, we have to work as a team. We cannot deliver quality care to a patient if we aren't working as a team and talking about it. Poker rounds, which we do in the morning to really assess who's ready for discharge, or who could be if they had fill in the blank. We can't do that with just the nurses. We need the doctors involved. We need the care manager involved. And sometimes we need other of the ancillary supports like physical therapy. If you do poker rounds on an orthopedic unit, yeah, we're going to need physical therapy there. So we can do some things internally to really maximize our communication about that patient by devoting a few minutes each day at the beginning of the day to kind of get everything moving, and we're all on the same page. Same way with the care plan, we're all on the same page, so the patient's getting that constant communication from every caregiver that's the same. It's the number one complaint I get from patients.
Well, I'm going to call you to task here on that.
I know.
I'm going to give you a question that came over the internet. It says, I've heard, this is an opportunity to be a myth slayer. I've heard on multiple occasions that UTMB does not hire its own nursing school graduates and its own health profession graduates. However, we continue to reimburse people to obtain nursing and other degrees. Why do we do this if we're not going to hire them? Is this true?
Baloney. We graduate, and actually the experts in the audience, Dr. Marshall said he would have the numbers if you want to know, but we make it, we strive to hire our own nursing grads in particular, where we have openings. We want to make sure that we can capture those graduates, and because they're some of the best. I mean, I've said before, our nursing school is a staffing agency for most of Houston. I mean, everybody wants our nursing graduates because everybody knows how good they are. We are among those, and one of the reasons we have been successful, I think, is that we have achieved magnet status. I'm really proud of that over the tenure, and we've had it re-verified. But once we hire those new grad nurses, then we do a residency, about 6 months, to help them really learn from an experienced nurse to be able to be a great nurse at the bedside. So there, we've done that. We've also, if we've had openings, we do prioritize our school of health professions. I don't think we've, over the years, had, at least recent years, as many openings, but we definitely need to look first to our own new grads, because you're right, we've invested in them to get them trained to get their degree. Sometimes we invest in our own to go from being a medical assistant, they go back to nursing school or another, and they get a degree. We should be taking advantage of that. I completely agree with whoever wrote that. And if, as I said, I don't have the statistics, I'm sure Dr. Marshall would have them at the top of his head, but we make a very concerted effort. In fact, the year where we cut so many positions last year as we were doing the budget, we still put in for about 20 new grads that were coming out in December. Is that, okay, I'm close. I can tell I'm not right by his face, but I'm close. But we've really tried to hire those because they are the best. They're great nurses. We want them.
So you saw it first here in Levin Hall. That myth has been slayed. So if you know some nursing graduates, don't hesitate to encourage them to apply here. I know one that you hired here, and she went on to work at another hospital, and 1 year after your training here and a nursing graduate degree here, she was voted Nurse of the Year, a new graduate.
Yeah.
So I agree, they are well trained and in demand. Now, the big question is, this isn't on your list you've seen before, it's to all of you. Can we afford to compete financially with those highly desirable staff members out there? Other hospitals are offering sign-on packages, all sorts of things. Are we now in a position to compete with them?
I can go first. Y'all are going to get tired of hearing me talk, I guess, today. But I would say that we have not been as on point about that as we should be. It's been, and I'm just going to use nursing, and honestly, I hope I'm not offending anyone who's in any number of positions here at UTMB. I just happen to know this one well because we've been really looking at it. We need to make sure that we are market competitive for our positions. We have not had a market salary review for a few years. We have just gotten one, and this one's for nursing. We have it for a number of places. So again, please, it's not just about nurses. It's the one I know best today because I've been looking at it. We have to pay a competitive market rate. Does that mean we have to be at the top? Probably not. Does it mean we'll be okay at the bottom? Probably not. We need to come in where we are positioned that when we look at our salary, we look at our benefits, and we look at our environment, it's an attractive place to work. And it's, salary's important, but the number one reason an employee leaves his or her job is not salary. It's in the top three, but it's their boss. So the other thing we need to do is make more of an investment in training managers and supervisors, people who are managing others, to have the tools to do a good job. So yes, we have to be market competitive. It doesn't mean we'll always be the top.
And Ms. Sadro, in the financial operations of the university, it's my understanding that's built into our financial planning, that you're working regularly with HR and doing that. I know many of our employees have concerns about the future and career. And I think it's important that we share with them that that's a part of the plan. It's not just cut, but it's manage, so that we can address those things. And certainly, I believe that's built into your plan for the academic enterprise too, Dr. Bhardwaj, is it not?
Absolutely. I think we need to remain competitive in terms of salaries and so on. We have benchmarking. It's more challenging for researchers rather than clinicians. We have MGMA or AAMC benchmarks for clinicians, but less so for researchers, and that's a challenge. And that is where the bidding power comes in to recruit them elsewhere. But it's not all about the money. I think it is also important that we need to create an environment that is conducive, a nurturing environment that is collaborative. And indeed, UTMB is that environment. At least that's the feedback that we get, that this is a great place to work. The morale is high, that people are actually caring for people, and that we put a lot of stress on professional development and other things.
I also want to just get your ideas, Dr. Bhardwaj. We're seeing a huge proliferation of medical schools throughout Texas right now. We have 3 or 4 more coming online over the next 2 years. What is being done at UTMB to assure that we remain the medical school of choice for top students?
Excellent question. So by my count, I think we are going to have 16 medical schools in the state of Texas very soon. So going back to the history again, as it's been stated, UTMB has a profound, strong history of being the oldest medical school. It's been stated, the statistics suggest that every 1 out of 6 docs in the state of Texas have gone either to medical school here at UTMB or done residency here. So we have a very proud tradition here of clinician educators. Now, there are medical schools that have a different flavor. Just to give you an example, UT Southwestern, for example, has 8 Nobel laureates, 6 or 8 Nobel laureates, and they're very heavily research oriented. We at UTMB here have been very proud of having the tripartite mission in terms of very strong clinician educators and researchers as well. I think we are more balanced. So I think if I was to project into the future, UTMB will remain in that domain of creating great clinician educators, community docs, or even academic clinicians. I think the challenge, just returning back from the AAMC, is how do we really have this connectivity between undergraduate medical education and general medical education. There seems to be a disconnect. Even getting into medical schools, the criterion for that, just relying on scores alone, USMLE, rather than having core competencies and so on, that is a national debate. And that really would translate also into the methodologies of us as educators. I think our interprofessional education program is going to be a very exciting new field, but we have to think ahead in terms of credentialing. Ms. Sollenberger talked about team approach. Healthcare is not golf, it is football. It's a team management. And I think that is going to become more and more important. In fact, it's been suggested that academic medical centers are going to be called interprofessional health centers in the near future, because that is the collective approach to patient care as well as research and education.
Good, thank you for that very thorough answer. Something that's on everybody's mind, and dare I go there, I'm going to go there. The fiscal year 18 budget deficit. What steps have been taken or implemented to avoid that happening in the future? And what did we learn from that experience? I'm looking at you, Ms. Sadro, because you're closest, not that you have all the answers. These other two can chime in anytime.
Well, I think if everybody remembers, part of what happened in fiscal year 18 was a hurricane called Harvey. So that had tremendous impact on our organization. If you remember, we talked about the fact that patients were putting off a lot of their elective care because they simply didn't have the time or resources to come in and have that care done. And JP Morgan had actually done some research, and about 65% of healthcare costs were discontinued immediately after the hurricanes for those areas that were impacted during that summer, fall of 2018. So it wasn't just us, it was Florida and certainly some of the other countries that had some pretty big impacts from hurricane. So we had about a $10 million deficit just from Hurricane Harvey. We did have some acuity and reimbursement challenges during fiscal year 18 as well, but mostly it was Hurricane Harvey. So I'll come back to that conversation we had a little bit earlier about it's not that it's so much UTMB as it is the country. We certainly have to pay attention to what's happening in our organization, but healthcare is changing. And that tends to be the area that we're focusing on right now, because that's the area that's really being impacted probably the most. Certainly NIH funding is not what it used to be either. But we really have to pay attention. That's what some of the consultants, not some of them, that's what the consultants have been here trying to help us do. So they've identified about 184 million in initiatives that can help us stay on track as we begin to see things change. So that's how we, get ahead and develop our own new normal. We've implemented, I think, about 25% of the total number of initiatives they have, and then the remaining portion of that is in the process of being implemented, or what we're calling confirmed, meaning that we understand that the savings really is either being gained or will be gained just because of the type of initiative it is over several months. So that's really where we're going to help ourselves most in the deficit part, if you will, paying attention to what's going on in the organization and in the industry, if you will, and reacting to it proactively, certainly not sitting back and waiting for things to happen. As Donna mentioned a few minutes ago, we've got to look at what's happening, we've got to understand what's happening, and we've got to take the actions necessary to make ourselves continually viable. So we're here to take care of patients. So it's not about the deficit, it's about how do we look forward, understand what's happening, and react in the appropriate ways to what's going on in our environment.
Do you concur with that, or you have a different view?
I concur. I think that the questioner may have wanted, what are some of the specifics too, and I can speak for the healthcare part. We have, when we look at ourselves today versus a year ago, we have 300 FTE fewer doing basically work where in certain areas we've overcome the dips that we saw from Harvey and are actually moving forward. So if some of you say it's exhausting, we feel we need some more support, we agree in some areas that is correct. Now we have implemented some new technology that's going to help us look at, based on our census or based on our volume, how many individuals would we need, and be able to make adjustments as we go, not just throughout the week or month, but as we go throughout the day. It can adjust every 4 hours. It gives us information. I think that's one of the tools that's going to help us stay on track. We also realize that we're an organization with variable volumes and census, so how do we make sure we have people that are available so when the census goes up, we see some additional staff are deployed. So Dr. Marshall and the nursing leaders have worked on the resource nurse concept. This is someone who can come and help if a unit is short staff. We need to do, and I know Ann O'Connell's working on how do we do something similar in the clinics, a little more challenging because you're so geographically dispersed. But we think there's some solutions to that. And then there's some areas that just plain, we're going to need to hire some more staff. We've looked at, Dr. Marshall's analogy that last year we were bleeding. We put the tourniquet on. We stopped the bleed. In some places, it may be a little too tight. So we're going through and looking at those. And as we go through the budget, it's going to be very data-driven to look at what is it that we need to continue to adjust. So if you're feeling as if we're doing a lot, we are doing a lot. And we are doing more than we were this time last year, and we're doing it with fewer people. Finally, people always like to say, well, if you all had just, if you didn't have so many administrators. Well, I'm retiring, so there's one. No. But we have done, in the health system, I know, a very vigorous look at that. And as I was thinking through, just in the office where I am alone, we have not filled about 3 support positions. It's not a big office. And we're down 4 VP, AVP positions. So, and that's the case throughout all of the other areas in the health system. So we really have tried to lean the management, and some of the managers are here today and they're saying, that's why I'm feeling so tired, Donna. I know, but we've tried to lean that as well, so it's not just all carried on the back of the frontline staff, and instead potentially has preserved that, more of that, so that we can take care of patients, which was one of my concerns.
So again, these kinds of things are going to be ongoing.
Yes.
That's what I'm hearing all of you say.
Yes.
That is the new norm in healthcare. And if I can use a terrible metaphor here, it's no different than someone who comes to our health system seeking treatment for an illness, be it a heart attack, a stroke, or what. We get them through that acute event, like we've done with this most recent financial challenge. We can't do much about a weather event other than learn from it and be prepared in the future. But everybody that comes in here for treatment for a definitive event, there's an opportunity to improve continuously their function, whether it's through cardiac rehabilitation or stroke rehabilitation or whatever. And I guess we will move into that rehabilitation area as an ongoing thing of fitness for the university itself. Like we would keep our patient fit, we will look to keep the vital signs of the university in all those areas on our dashboard and be sure that we're hitting our targets in the future. Thank you very much for your words of wisdom today. And again, things do not happen in a detached manner. They happen because there is organization and leadership. Our main leader is not here today. Dr. Callender is away on business. So remember, there is a direction. You have heard it said many times here today, a sense of where we're going in that future that's carefully planned out, and you have an opportunity to be a part of it. It's not going to be a pleasure cruise in some areas. It's going to take work, but that's what we're here to do. The end result, as Donna says, is our people who work here and our patients. Those are the 2 things that we need to keep our eye on in those vital signs. Thank you for being here today. I will stop precisely at the right time where you can still get warm popcorn. Thank you.
UTMB Health, working together to work wonders.